Good morning, ladies and gentlemen. I'm a chairperson in this session, Classification Prognostication. My name is Hideki Makishima from Shinshu University, Japan, and we will chair together with...
My name is Dr. Elsa Bernard from Gustavo in France.
We have three invited speakers. And the first speaker is Elsa Bernard from Gustave Roussy, France. So please start the presentation. Could you? So her presentation title is Molecular Classification, Molecular Prognostication.
All right. Good morning, everyone. It is a great honor to kick off this, what will be a very exciting meeting, and I would like to thank you, the organizers and the MDS Foundation, for this great opportunity. So this morning I will be discussing with you molecular subtypes of myelodysplastic syndromes. So as we all know, the diagnosis of myelodysplastic syndromes, MDS, is based on a combination of parameters to include clinical parameters, morphology, immunophenotype, as well as cytogenetic alterations and gene mutations. However, the genetic heterogeneity in MDS has really challenged since many decades the delineation of distinct genetic subtypes that can be then incorporated into clinical guidelines. We know that there are more than 50 genes that are recurrently mutated, and on average, patients do have 3 to 4 driver mutations that drive their disease. And as a consequence, in current classification criteria for patients with MDS, genetic subtypes such as MDS with isolated 5q, MDS with SF1 mutations, or MDS with B-allelic TP53 alterations only account for 20 to 30% of all patients. And so today, and there have been several studies that have demonstrated that it is possible to incorporate the molecular profiles observed in patients into distinct subtypes. Yet there is no consensus on how to delineate those different genetic subtypes across the study. So the goal of today's talk, primary goal of today's talk, will be to, on behalf of many colleagues and collaborators from the International Working Group, to describe the study on the derivation of a molecular taxonomy for MDS and to define its clinical implication. So we analyzed 32,000 patients with MDS-related neoplasms that were diagnostic samples treatment naive from adult patients that had less than 20% blast or 20 to 30 with no AML recurrent alterations. And those MDS samples were analyzed as previously described with a 152 gene panel with a 2% VIF cutoff and genome-wide probes to call allelic imbalances. We integrated those genetic alterations, and we observed that gene mutations were present in 91% of patients, copy number alterations, CNA, in 43%, and copy neutral loss of heterozygosity, or CNLOH, in 11% of patients. And most patients with CN allelic imbalances had concomitant gene mutations. We demonstrated that the importance of distinguishing between different hotspots or different allelic states to perform genotype-phenotype analysis, and so to further be able to delineate precisely different genetic subtypes in MDS. This has been previously shown in the context of TP53, which is now a biomarker for MDS classification. And here we show that patients with a different hotspot for U2F1 have very distinct commutations patterns that suggest that they have different disease history. And this is also consistent with prior transcriptomic studies that show that patients with a 2U2F1 hotspot at position 157 and 34 also have very distinct splicing event alterations. Similarly, patients with B-allelic or monoallelic TET2 mutations had different clinical profiles with a strong enrichment for CMML or CMML-like phenotype for patients with B-allelic TET2 mutations as opposed to monoallelic TET2 mutations, also consistent with prior studies by colleagues from the Cleveland group. So the methodology we took to define genetic subtypes of MDS was to use molecular features to combine gene mutations, cytogenetics, as well as coprintal LOH, as well as previously described, allelic state and hotspot, into features for unsupervised clustering analysis, and those clusters were further processed to really isolate the strongest signals of commutation patterns and to define a classification-based tree of the disease. This allowed us to build a hierarchical classification tree, which is a molecular taxonomy, resulting in 18 groups. Those groups are defined based on the presence of mutation in 21 genes, 6 cytogenetic events, and L-weight at TP53 or TET2 locus. In total, we had 16 molecular subgroups that comprised 86% of patients, and 2 subgroups were based on negative findings to include the molecular not otherwise specified subtype and the no event subtypes, where we did not find any driver alteration that comprised 6% of patients. The first 6 groups were based on simple biomarkers, and there were the subtypes defined by DGX41, AML-LAC, TP53 complex, derivative chromosome 17, a minus ZBP1 subtype, and a del5Q subtype. The following 4 groups were more complex, with a higher number of mutations per patient and based on more complex rules of commutations. And those groups were EZH2-SXL1, IDH-STAC2, BCOR-BCOR-like, and B-allelic-TET2. The following 5 groups were residual groups based on the residual presence of splicing factor mutations in U2F1, one of the 2 hotspots, SRCF2, ZRCF2, and SF3B1. Last, we had a group called CICUS-like for clonal cytopenia of uncertain significance, as well as the negative findings not otherwise specified and no event. Altogether, 5 of those subtypes have been corresponded to well-characterized entities. 3 of those subtypes have been previously reported and described in the literatures. 8 subgroups were novel, and 2 were the negative subtype. We found that those different genetic subtypes had distinct association with clinical presentation, and this is an example of the association between subtypes and bone marrow blast, where the median bone marrow blast across the different subtypes range from 1.5% to the lowest group, to 10% for the highest group. So the lowest group were SF3B1, no event or CICUS-like, for example, and the highest group were AML-like, DDX41, TP53 complex, and the IDX-STAC2 subtypes, which had a very secondary AML-like genetic profile. Beyond the blast, we observed strong association between the subtypes and the range of clinical phenotypes, as shown here by this heat map that summarize those associations between molecular subtypes in columns and phenotypes in rows, where we did, of course, recapitulated previously known associations such as 5q-SF3B1 and anemia, BTET2 and monocytosis, DDX41 and neutropenia, for example, as well as identify novel associations such as BCOR-BCOR-like and thrombocytopenia, IDH-STAC2 neutropenia, among others, as well as indolent phenotypes for groups which were defined based on negative findings or sickle-like, or which should be validated in further studies, the residual ZRCF2 group. Those MDS genetic subtypes were also associated with distinct patient outcomes for overall survival and rate of leukemic transformation, where the median overall survival across the groups ranged from 0.9 years for the TP53 complex and AML-like to 8.2 years for the no-event subtype. And similarly, the rate of AML transformation at 2 years ranged from 0% to 40%. So, in addition to providing a tool for further study of both classification and diagnostic system, as well as therapeutic research, where one should probably investigate therapeutic response in the lens of the genetic subtypes, this molecular taxonomy also provides a framework to study either novel mutations and their relationship with the different subtypes, or the relationship with clinical parameters, or some overlap disease or different disease subtypes such as therapy-related MDS or overlap syndromes of MDS-MPN. So briefly, in a few slides, after the seminal study of Dr. Beck that we will be hearing this morning as well, that described the presence of UBA1 mutations in a new autoinflammatory syndrome called VEXAS, we decided to investigate for the presence of UBA1 mutations in the IWG cohort. And for this, so UBA1 was not in the gene panel to start with. So we used a 2-step approach where we first selected a cohort A of 375 patients that were male exclusively, and that were heavily selected from having either MDS unclassifiable per WHO, or MDS without identified driver from our previous analysis, or only mutations in clonal genes, such as DNMT3 and D2. And then we also performed a cross-section analysis of 277 patients that were not selected, where we analyzed this cross-section cohort by NGS targeted panel, while for cohort A was a ddPCR, digital droplet PCR assay. So when we did that, we observed mutations in UBA1 that were either classified as pathogenic, likely pathogenic, or variant of not significant. The pathogenic mutations were heavily driven by the M41 hotspot, but we also observed a few other pathogenic mutations that have been previously described in the literature. And the variant allele fraction of the likely pathogenic variants were higher than the VUS variant. For the cases that were profiled by both ddPCR and NGS, we observed a perfect correlation of close to 1 between the droplet fraction and the variant allele fraction of NGS versus ddPCR. So in summary, when we analyze those mutations, in the first cohort that were selected for male without genetic drivers of MDS, we observed a very high prevalence of UBA1 mutations in more than 7% of this cohort. In contrast, when we analyze the cohort B that were not selected for absence of genetic driver of different subtypes, we observed a lower prevalence of 1.7% presence of UBA1 mutation and only 1% of pathogenic UBA1 mutations. So really, this suggests that UBA1 mutation define a specific subgroups of MDS or MDS VEXAS overlap disease, and in particular, we observed that those patients that were UBA1 positive were, for the vast majority, diagnosed as MDS SLD MLD. More than 7% of those patients have very low risk or low risk by IPSS-M. And when we perform clinical review, thanks to the very active implications of the collaborators, both morphology and clinical review of those positive cases, we observed that 70% of those patients had vacuoles and 83% of those had inflammatory clinical presentation. So altogether, this suggests that UBA1 mutation should be considered in the diagnostic workup for this MDS VEXAS overlap. So the next thing that allows this molecular taxonomy to do and that may inform future classification efforts is to study the relation between a genetic definition of disease and blast percentages. So first we did observe, we took the different blast strata, the established blast strata of 0 to 5, 5 to 10, and 10 to 20% of blast, and we looked at the representation of molecular subgroups within each one of those strata. And we did observe that it was very heterogeneous, where there was 9, 7, or 8 recurrent molecular subgroups across those three different strata. When we perform multivariable analysis for overall survival in that case, but that was true across endpoints, both genetic subtypes and blast strata were independently predictive, which was in contrast to some prior studies. So we wonder then if the prognostic influence of blast could depend on the genetic context. So for this, to analyze this hypothesis, we selected the molecular subtype that had patients that had variability in the representation of blast. So we had there are 12 molecular subgroups with at least 10 patients in each one of the blast strata, 0, 5 to 10, and more than 10. Those subgroups range from SF2B1, CICUS-like del5Q to AML-like. And within each one of those subgroups, we stratified patients' outcomes with blast percentages. This is shown here for the full cohort at the top, where each line represents each one of the blast strata for median overall survival, with a strong stratification with blast. And when we did that across, the different molecular subtypes. And we did observe a strong stratification for different subtypes, in particular the subtypes that are typically associated with low-risk disease, such as SF2B1, CICUS-like del5Q, and others. However, for some genetic subtypes, there was no stratification whatsoever with percentage of bone marrow blast, and this including the subtypes of AML-like and DDX41, as previously demonstrated, but also other subtypes, such as the -7 ZBP1 and the EZH2SXL1 subtypes. And interestingly, those subtypes, within those two subtypes, more than 50% of patients have low blast disease. However, the median overall survival was poor across, the overall survival was poor across blood strata for those two subtypes, with a median overall survival of less than 2 years independently of the blast representation. So just to conclude this part, and I'll go back to that in the conclusion, that we believe that this provides a rationale for potentially in the future use genetic definition of disease as a basis for classification, and that blast really should designate the stage of the disease within genetic subtypes. Last, maybe the last point I would like to discuss is how to use a molecular taxonomy of FDS to study different disease entities, such as therapy-related MDS and overlap syndromes of MDS-MPN. So in the cohort, we analyzed 267 patients with therapy-related MDS and 536 patients with MDS-MPN. And we analyzed their distribution across the different genetic subtypes. And we did find a high heterogeneous distribution of genetic subtypes within those two disease entities, where, for example, for the TMDS part, there were certain groups that were represented in this disease, but 7 groups were highly recurrent with more than 5% of patients. They were, as expected, enriched for the TP53 complex subtypes, as well as the -7 ZBP1 subtypes, where isolated -7 is also known to be enriched in this disease. However, there was other subtypes, even the low-risk SF2B1 subtype that were observed in 9% of those patients, as well as other subtypes such as the IDX-TAC2. Similarly, for the MDS-MPN overlap disease, we observed 15 groups recurrent in that disease subset, and 6 groups were observed in more than 5% of patients. A very strong enrichment, as expected, for the B allelic TET2 subtypes, enriched for CMML, MDS-MPN RST enriched for SF2B1, and atypical CML enriched for the EZH2SXL1 subtype. However, again, we observed a high heterogeneity that spread across many subtypes in the overlap MDS-MPN. So these, the 4 most frequent subtypes in MDS-MPN were BLT2, IDH-TAC2, EZH2SXL1, and -7 ZBP1, where we can compare here that the distribution of gene mutations were really similar, as expected, categorized similarly between patients that were classified as MDS or MDS-MPN within those different genetic subtypes, where, for example, in the -7 ZBP1 subtypes, there is total absence of TET2 mutations compared, obviously, to the allelic TET2 subtypes. Patients that were classified within the allelic TET2 subtypes as MDS had higher monocyte count than patients that were MDS in other subtypes, and this may provide a better rationale than the arbitrary cutoff of monocyte counts. The one molecular difference between patients with MDS or MDS-MPN was a strong enrichment for RAS pathway mutation in MDS-MPN over MDS, not only in frequency, but also in variant allele fraction, where the median variant allele fraction was 20% in MDS-MPN versus 10% in MDS, and the variant allele fraction of RAS pathway mutation was a strong predictor of monocytosis in multivariable analysis. And last, when we compare the clinical profiles, so both for clinical presentation and outcomes of patients with either primary MDS and therapy-related MDS on the one hand, or with primary MDS and MDS-MPN on the other hand, we observe comparable profile for clinical parameters and outcomes, and this is just showcased here by overall survival within 2 subtypes of -7 ZBP1 and SF2B1 for patients classified as therapy-related MDS or primary MDS on the one hand, and on the right, this is illustrated by Kaplan-Meier curve for MDS or MDS-MPN within the subtypes of IDH-TAC2 or B allelic TET2. So this suggests that the genetic backbone of the disease may drive the phenotype across disease boundaries in some instances. So with that, I would like to summarize this presentation on the molecular taxonomy of MDS. Based on the analysis of the molecular profiles observed in patients, we defined a molecular taxonomy of 18 groups based on a few number of genes, 21 genes, 6 cytogenetic events, and LO8 at TP53 and TET2. 86% of patients are classified based on molecular subgroups, but the rest is classified in negative in groups defined by negative findings. And those MDS genetic subtypes had distinct association with clinical presentation and patient outcomes. The relationship between the genetic subtypes and blast percentages may suggest a novel paradigm for future classification, where genetic subtypes should be the basis of classification and blast a designator of disease stage. The taxonomy provides a framework to study genetic heterogeneity across disease entities, where, for example, we observe that UBA1 mutations are frequent in the patients in the subset of male patients without a molecularly defined subtype. And within genetic subtypes, we observe comparable clinical profiles and outcome profiles between different disease entities of primary MDSR, purulent MDS, and MDS-MPN. This taxonomy may inform, and this will need to be investigated in the future, therapeutic research and treatment development. So with that, I would like to acknowledge deeply all the collaborators from the International Working Group for their involvement in the study. This was a huge collaborative effort, as well as constant support from the MDS Foundation. I would like to thank you again, the organizers of this symposium, and you for attention.
Thank you so much for such an informative presentation, Elsa. There's a time for discussion. Could you start, Dr. Miyazaki?
Okay, I'm Miyazaki from Nagasaki University. Elsa, thank you very much. Always very nice talk. I have a question about UBA1 mutation among the 7% of the patients. Mm-hmm. And actually, these are not germline mutations, right? They are germline.
They are. I mean, they are or they are not. You said.
They are not germline.
So probably they're not germline. I mean, the distribution of variant allele frequencies suggested they were predominantly not germline, but we don't have a match germline control. So there was a fraction of cases with close to more than 90% VAF where we could not be certain.
Okay. But some of them had inflammatory symptoms.
More than 90% of them, more than 80% of them had inflammatory symptoms. And the time from, although this could not be perfect, the diagnosis for the cases that got a diagnosis of inflammatory disease, it usually preceded the diagnosis of MDS by 3 months.
So the presentation was similar to the VEXAS syndrome. So
for a fraction of them, it was similar. Mm-hmm. So this is retrospective data. So the typical, the annotation we had will not be the same now that VEXAS is a described clinical entity. However, for some of them, there have been diagnoses of inflammatory rheumatic disease, and from other, it was there have no diagnosis, but there was clinical manifestation of inflammation.
Okay, thank you.
Dr. Nanya, please.
Thank you for nice talk. I'm Nanya from Tokyo. And you applied a stepwise approach to define taxonomy of MDS. And I think this is a good way to put all the cases into exclusive category. But I have a question about how did you define the order of gene mutations that was prioritized to other gene mutations in defining taxonomy of MDS?
Yeah, so it's a good question, a bit methodological. So the order was such some patterns of commutations are based on exclusion. So the order was to reflect the fact that subtypes could be defined by the co-occurrence of 2 gene mutations, but the exclusion of others. So by doing it hierarchically, this is equivalent to stating in the exclusion of type 2B allelic, del5q, and others. So the order was mostly to reflect the exclusion of alteration observed in the molecular clusters. For some, then the order was also based on prior knowledge to reflect the known, the previously defined entities such as DDX41. There was no reason to put DDX41 versus type 2 complex one before the other. This is arbitrary.
Thank you.
Hi, Elsa. Great
Hi.
talk. Just for everyone's benefit, when you looked at the blast count, was the blast treated as a continuous variable, or was the blast, was the 10% cutoff used for your analysis? And what have you learned, if anything, about all the different ways that we think of these diseases based on percent blasts?
Right, so blast was, great question. Blast was used both as a continuous and as a category. So in analysis of, say, correlative analysis with outcomes of genetic subtypes and blast, whether you use continuous blast or stratified blast, it's significant. So this is a variable that has, you know, prognostic values either encoded as continuous or categorical. In terms of the representation within, then we consider the strata, 0, 5, 5, 10, more than 10, and we look at the different genetic subtypes within those strata. And when we did that, this is where we observed a very high heterogeneity, which suggests that, you know, the arbitrary cutoff results in, you know, in heterogeneity that is, you know, difficult to disentangle.
So do you have a recommendation moving forward for
well, I think
strata?
Yeah. So I think I think the primary recommendation of this study is that, which is maybe not a recommendation, but more of a finding, that the effect of blast depends on the genetic context. So if you consider the DX41, it doesn't matter what the blasts are or other subtypes. While clearly in a low-risk disease such as SF1, if you have excess blast, then it really means that, you know, something is going on and the disease is higher stage.
Okay, and one last minor thing. Some patients present with cytopenias and they get their genetics much later. And some patients get their genetics at the time that they present. So for instance, at least in the United States, if you're not seen by an academic physician, you may have seen somebody for some months. Is there any way to correct that time bias?
It's a good question. So we did have this value of time from, no, I don't know. We had the time from diagnosis to the samples that were sequenced. Sometimes there is repeated samples and we did correct for that. But for what you're asking, it when you get your cytopenia, I don't know. I don't have an answer for that.
Okay, thank you.
Beautiful talk. I just wanted to congratulate you for beautiful data. I have a question. What makes treatment-related MDS treatment-related MDS? In other words, if somebody would get MDS 1 month after the diagnosis of the primary cancer versus 20 years, how do you define it? And because obviously there is a coincidence, there are people who get 2 cancers, there are people who get 3 cancers, and there are also people who, you know, coincidentally just have 2 cancers because of genetic predisposition, etc.
Thank you so much. I think it's a great question. So in this study, we use the definition of therapy-related MDS that were given as a diagnostic to the patient. And indeed, as you mentioned, this definition is purely chronological. If you develop MDS, provided you had treatment for prior cancer, whatever the timelines, if it was 25 years before 20, at least in the previous WHO, it was classified as therapy-related. And here we show that when we looked at, you know, the genetic subtype of those therapy-related MDS, some probably have the typical hallmark of therapy-related MDS being, you know, selection of TYP3 mutations and genetic instability following alkylating agent exposure. But for some others, probably they're not driven by that at all, and they might be. This is hypothesis now they might be just a secondary disease unrelated to the primary one. So I think this is a great question that deserves future study, and this is one of the future study that we're hoping to perform together with the IWG in the next few years.
Thank you.
So maybe because of the lack of time, but the quick question, please. Yeah, the motion.
Hi, Elsa. Huge, super talk. I would like to go back to the blast issue, which I find extremely interesting and useful. And I would try to be even more provocative than you. Would you say that if genetics can be done from peripheral blood, And blast, probably I will be even more aggressive, and I would say that maybe blasts are not as important as we thought in the past. And I would apologize to John Bennett, Peter Greenberg, and others. Maybe at some point we can stop doing bone marrow and just do peripheral blood. What do you think?
So I don't think I'll be as provocative as you are, because blast remains one of the, even if we're not talking about genetic subtypes, if we're only talking prognostication, blast is one of the most prognostic variables. So yeah, I wouldn't go there that far.
So Elsa, thank you so much for such a fantastic presentation. So as you see, unfortunately, the next speaker, Jaroslaw Maciejewski, will present online because of family affairs. The presentation title is Validation of IPSS-M and Molecular Classification. Jarek, could you start?
Thank you for the invitation, and I would love to be with you guys in Kyoto. I wanted to, full disclosure, this was a topic that Professor Ogawa gave it to me. I am, sort of not necessarily a classification and slicer and dicer guy, but, definitely it's an important topic, but for me it's a very difficult act to follow after this excellent presentation of Elsa. So my task was to talk about IPSS-M that have been announced now a couple of years ago, and it incorporates genetic mutations in order to increase granularity of the precision of the prognostication. We charged ourselves with a task of seeing whether in real life scenario we can exactly apply the same algorithm and see whether our results will be similar, particularly with regard to the improvement of prognostication above and beyond what's done purely using clinical parameters such as in IPSS-R. So as you can see, we use a quite large cohort of 1,281 patients, a similar distribution of individual parameters. Maybe one particular exception was the fact that our patients were mostly treated versus the treatments in the patients in the original study by Ellie and Elsa were mostly untreated. So this is a confounding factor that we couldn't avoid because we just didn't have this many untreated patients. In any event, the distribution of individual mutations was very similar. It's just pointed out here in this diagram. As you can see, as predicted, P53 is more common in very high and high score groups, and conversely, the low-risk mutations such as -Y or SF3B1 have very low representation among very high-risk groups. Now, once everything was done and we compared IPSS-M using the algorithm that was provided by the original paper and to our patients, we also found similar results in terms of the upstaging of the low-risk patients and downstaging of some very high-risk patient to high. So in summary, out of 46% of patients that were restratified from IPSS-R to IPSS-M, 70% of those 46 were upstage and 30% were downstage, which is a sort of comparison to the original patient cohort that was used for the for creation of the IPSS-M. Now, it's a very complicated slide. I'm not going to go into the detail, but the basic take-home message is that with exception of high and very high IPSS-R subgroups, we were able to further substratify patients assigned to similar IPSSR risk groups, and this is consistent with what Elsa and Ellie have shown. However, there were significant differences. Again, the overall survival, leukemia-free survival, and progression-free survival were very well separated by both classification scores. However, IPSSR and IPSS-M showed similar C indices. C index is a marker for precision of the prognostication. In other words, the delta between between two different scoring systems gives you the gain of precision. And we were unable to show it in overall. In terms of leukemia-free survival and overall survival, there was 2 and 2.8% respectively increase in C index from IPSSR to IPSS-M. The original paper showed 5% increase. For both IPSSR and IPSS-M, we were able to do subclass analysis. The C index increase was notable only in the untreated group, and which explain why the overall C index increase in IPSSR was lower in our cohort in this real world scenario. We also were able to do this time-dependent value. So the time-dependent receiver operator analysis showed a global increase in area under the curve for LFS in untreated as compared to treated cases. A time-dependent increase of AUC, for PFS and favoring PSF was favoring the untreated subgroup was also noted. And no difference was observed for overall survival estimation between both groups. So in conclusion, for this portion of my talk, our comprehensive validation cohort with really mature clinical outcome data could not find significant differences between IPSSR and IPSS-M when calculating C indices and time-dependent ROC for clinical outcome. The significant added prognostic value of IPS-M in original study was likely a result of substantial fraction of untreated patients included, which we did not have. Multiple validation studies can further assess the novel score, the novel score and clinical practice and ensure reproducibility of future application in clinical trials. And I think, I would like to finish with the conclusions that new algorithms have to account for special circumstances, and let me mention a couple of them. So of course, the configuration, and as Elsa showed, particularly P53 is a good example with subclonal chimerism, hemizygous and homozygous mutation, the clonal burden issues, particularly the clonal burden difference between peripheral blood and blasts, whereby the blasts carrying the mutation are arrested and do not contribute to mature blood production, whereas blood has a dilution of the VAF and clonal burden. The different type mutations within one distinct gene might have different impact, and CBL is one of these of examples, but we can of course name many others. Rare mutation might be underrepresented because of the statistical method used to measure the impact on survival and what goes in as a parameter. And the special type with skewed nature history might be a subject of separate analysis I want to only mention a study that was conducted by Dr. Gurnari from our lab for post-aplastic anemia MDS. The treatment-related MDS, of course, is another example. And patients with MDS who were treated with hematopoietic stem cell transplant might have special consideration, which would possibly change the prognostic value of the IPSS-M or any other classification for that matter. So just one slide to show Carmelo study published in Blood a couple of years ago. And as you can see that according to IPSS-M, the majority patient clustered in a higher risk categories. So this is a sort of boutique category of MDS, and we were able to gather a lot of patients with this type of MDS, and they had poorer prognosis than expected by IPSS-M. Now, this slide and just should represent the impact of position of the mutation and on outcome, and Elsa mentioned it already for U2AF1 with S35 and 157 ring finger domain mutations. Here the symbol is of course either ubiquitination domain, the ring finger domain described originally by Dunbar from my laboratory in the JCO papers almost 20 years ago. But we find now also mutation in that are truncating, and they don't have, of course, PI3 activation domain. And as you can see, the fraction of patients with AML versus patient with also in MDS is different. And we are currently looking whether it would have an impact on prognostication. Another words lumping the two subclasses of mutations which have different impact on outcomes might result in erroneous not inclusion of these mutations into categorization scheme, and of course dilution of the clinical impact. Now, P53 is a separate issue, and everybody is interested in this gene. And original IPSS-M, Elsa might correct me if I'm wrong, just took the biallelic mutation. So two different mutations were considered as biallelic, and they were hemizygous and homozygous mutation by copy number analysis. But things are really by far more complicated, and it is possible that two different mutations do not overlap, and this is a subclonal chimerism as indicated here, and this once more a different way of showing it. But also, the linear evolution might be caught by our sequencing at different stages, and of course, whether patient has hemizygous or homozygous mutation might not be clear from just simply VAF and saying that anything that is above 50% is biallelic or homozygous or hemizygous, and other biallelic loss, because even smallest clone, as shown by single-cell DNA sequencing, might contain already biallelic subfractions. And we perform random forest survival analysis to benchmark this particular issue and to determine the variant allelic frequency cutoff at which the survival changes. And we came up at 23% cutoff value, which was validated by single-cell DNA sequencing. In other words, if a combined VAF, as shown by this particular algorithm, a combined VAF of two lesions, whether this is copy number variant or homozygous mutation, which would be only one VAF, but the other possibility is that there's biallelic mutation. We add them together, and if they are above 50%, then of course this is a biallelic hit. But if they are below 23, that they are likely, probably monoallelic, and the gray zone is between 23 and 50%, whereas we are very likely to find a biallelic mutation despite the fact that the combined VAF is below 50. So this is a different argument, and if different way of calculating biallelic and assigning it. And using this analysis, we have, of course, for monoallelic, biallelic, and probable biallelic, very good separation between the curves. I think the VAF, as it increases towards, for sure, certainly biallelic, it sort of matters. In other words, the higher VAF is, the more likely we have biallelic hit, even if we detect only one mutation. And as you can see, the probably biallelic and obligatory biallelic are mostly in very high risk groups, versus the other are distributed all over. So So molecular clustering of myeloid neoplasia without prognostic benchmark and pathomorphology as a gold standard might be the solution, because we are introducing new treatments and they will of course affect the survival and affect the progression-free survival. And by this virtue, we would have to change each time the scoring system. And the other advantage of the survival unbiased or unsupervised analysis would be that it has similar to morphology agnostic analysis, that it would allow for functional subgrouping of patients who have similar pathway, convergent pathway towards a particular phenotype or particular sensitivity or resistant patterns to reflected drugs. So this is just an example of an unsupervised analysis, which resulted from the fact that when we took secondary and primary AMLs, we were unable, similar to other groups, to distinguish them based on mutational pattern. In fact, the multivariate logistic regression analysis show under a curve with a cutoff value of approximately 73%, and ours only 24% higher than 50% random, the predictive value of particular mutation or mutation pattern could be detected using this type of approach. However, when we did machine learning clustering of genomic lesions, and we identified 4 different clusters out of 2,681 patients with AML. And as you can see, the genomic cluster 1 contained purely primary AML, versus there was no distinction between genomic cluster 2, 3, and 4, although they were genomically uniform. The primary and secondary AML were evenly distributed. So, and of course, one does not want to use too many parameters, so we try to boil down the parameters, and using this analysis, namely to measure the mean decrease in accuracy, we identified if you wish, the signatures of individual clusters, so that we can distinguish them using lesser number of features. And of course, the molecular clusters show significant difference in survival outcome, despite the fact that the analysis was unsupervised analysis purely on molecular parameters. Now, the identified clusters also overlap with previously defined risk groups. So here you have ELN for acute leukemia, and as you can see, the adverse group, that it's further separated using our clustering method into different subtypes. So we can produce a better subclassification in terms of prognosis by molecular grouping of machine learning based algorithms, which do not include clinical parameter and survival in supervised fashion. So now, how about MDS? And this was such a wonderful talk by Elsa. We did something similar. We published it, as you know, in Nature Communications. We were counting on a better outcome, but this is a great journal. And so we essentially took a lot of patients, 3,500 patients. I'm sorry for this mistake. They are, of course, not 30,000 patients, but 3,000 patients. And we also had a validation group external of 412 patients from our colleagues from Karmanos and from UT Southwestern. And using this similar Bayesian latent class analysis using molecular and cytogenetic features, we outcome agnostic, we have identified these 14 clusters. These clusters have individual signatures with parameters that are either absent or the parameters that in a positive fashion provide a signature for individual clusters. And they have a distribution. As you can see, if you look at the outcomes like high risk and low risk MDS or secondary AML, or according to IPSS-R and IPSS-M, they are variably distributed between the clusters. And it's not surprising. Again, it was unsupervised analysis. But the most important finding is that why do we think that patients who live the same amount of time, would have similar molecular feature? Somebody can die at the age of 40 from car accident and from other disease. And thus, if we want to group patient according to functional or molecular feature, the primary goal would be to identify similarity or similar mutational pattern and combination rather than similar outcome, which might be affected by the presence on effective drug, for example. So molecular clusters were heterogeneous in terms of the clinical features, and most high-risk patients were distributed in molecular clusters 13 and 11. Molecular cluster 2 was the largest, including 26% of patients. And you see similar of this approach to what Elsa showed. She had quite higher number of clusters. In our case, and I see that I lost this particular slide for no reason at all. We did a bootstrapping and an elbow analysis to identify the optimal number of clusters. So this is not like we came up with 14 clusters just because we liked. There were other parameters that would extend the number of clusters, but at a certain point, it's not helpful. And similarly, to boil down to too few clusters, giving the heterogeneity that consists with our intuition. So the multivariate logistic regression analysis shows that, for example, cluster 9 and cluster 13 were associated with different HMA response rates. And we perform now this analysis for other, of course, for venetoclax and other possible mutations. So molecular similarity versus clinical outcomes. We then, for clinical calculation of impact on clinical outcomes, we subgroup the clusters into group 1, 2, 3, 4, and 5 based on similarity molecular association between the groups. So if you wish, like Uber clusters. And when we perform the survival analysis, these are individual clusters. And then we group them. And we had a very good separation. Again, original analysis was unsupervised. So in conclusion, despite complexity and diversity of MDS and AML, machine learning might allow for definition of molecular subentities irrespective of outcome and pathomorphologic features. I think future algorithms currently under development will include clonal burden, type and configuration or topology of alteration in individual mutant gene, pharmacotypic and pharmacologic information, and also possibly expression, PSI, or isoform utilization if we include RNA-seq. So just to close with the future outlook where we are going in the lab with this, we now try to match most of the patients with in vitro sensitivity screen. It was always since I was in medical school, I asked my question, why we do sensitivity antibiogram for urinary tract infection, but we don't do it for leukemia. And thus we have developed this type of assay, whereas variable number of drugs, in our case, around 60 drugs are being used and added by a robot in different concentration to primary cells, and the drug response by viability after culture is measured. And so our next stage of clustering will, of course, include different topography of the mutations, allelic status, microdeletions, and other molecular features, but we would like to marry them, if you wish, to correlate with results of high throughput drug screen. And the question is, which we are investigating now, whether we can correlate cluster with sensitivity and resistant patterns, or whether we would each sensitivity and resistance as an individual parameter in the multimodal setting to obtain something that we call genotypic pharmacotypic features and clusters that would allow to predict the sensitivity without drawing a drug screen, and potentially just by reduction of complexity of individual cluster to the key features that hopefully will be molecular. I just want to thank everybody for the invitation to Kyoto. I'm sorry that you guys are not with them. I saw a beautiful picture yesterday with Ginkgo, with the temple and Carmelo and Hideki and Professor Ogawa. As this is my lab, and thank you very much for listening.
Thank you so much. Thank you so much for such a fantastic presentation, Jarek. So, okay, please start. Microphone.
Okay, all right. Yeah, so the question is both to you and Elsa. In terms of like each time when we use these molecular clustering unsupervised or supervised, we look only at MDS and we don't look at AML. We are not looking them on a continuum, and we seem to come always with the conclusion that some patients, the blast count might not matter and they could be treated potentially like AML, DDX41 or NPM1, etc. But nobody is looking at AML and saying some of those patients should be treated like MDS. So the question is, why aren't we doing this, you know, in across the myeloid, aggressive myeloid spectrum? Thank you.
Elsa, do you want to take this one?
Go for it. Go for it. But
Uh,
okay. No.
Yeah, I think, you know, my feeling is, of course, that, you know, this type of analysis will not be performed in vacuum. So there will be a certain pretest probability. So I don't think that we are aiming an identification or a diagnosis of MDS. This might be eventually a goal, but for now, the goal would be to be able to subgroup patients based on functional similarity or, you know, irrespective of the clinical phenotype that might arise from convergence of pathogenic pathways that are triggered by a combination of mutations. And so yes, if we were talking about sort of, you know, diagnosis, molecular diagnosis without pathologists, then we would like to mix into this patient with other diseases, whatever, myeloma, sickles, low-grade lymphoma, and see whether the mutation pattern would distinguish it. But I think for now, the aim is to subgroup patients which we generally believe have MDS. There is a certain continuum, as Elsa showed, for MDS, MPN, and secondary AML, but this would be the task.
Second question to Elsa. What do you think about what Yorick shows about the molecular IPSS, the benefit in discrimination over the revised IPSS being mostly in patients who were untreated, since most of the patients with high risk would get HMA or transplant? Like, does it make sense to use molecular IPSS? Thank you.
Yeah, good question. So I'm not sure, Jarek, if in your cohort the sample were diagnosis, correct? Even if, right, for all of them, the treated and untreated? Yes?
Yes, this was the question. So if I may, I think, you know, the introduction of a magic bullet of a drug that will change the landscape, you know, similar to Gleevec, or potentially there are a couple of drugs on the horizon, venetoclax is already changing prognosis in certain patients, would make, of course, the predication or the validity of IPSS score as it is now questionable. So yeah, so the shelf life, unfortunately, of treatment agnostic predication of prognosis might be short. Elsa, what do you think?
Yeah, quick one, because I think we need to move on. But I mean, increasing C index is very difficult. So 2% in the validation cohort is not zero, right? But I'll be interesting to know if all the sequencing were done at diagnosis, even if the patients were treated after. But obviously, I mean, the evaluation of a new treatment will, we have to rethink some of the prognostication. And we know in subtypes, in particular the DX41, the IPSS-M does not apply. So there are some exceptions which should be considered.
No, absolutely, and I hope that Carmelo will show you the newest data to this result. He literally travels the world and collected EDX41 patients, and I think he is later today presenting the data.
So I have a follow. Hi, Jarek. It's nice to see you. We were together in a meeting
Yeah.
last week. So, first I want to thank Elsa for sharing this data with us. I think this question of the therapy, though, is really fundamental. And going back to what Amer was saying, I mean, Matteo have shown now the report a couple of times that this IPSS-M is really powerful predictor in the transplant context. It may be that in Europe, maybe, I'm not sure, they don't give therapy prior to transplant. But the reality is that most patients are really treated. So the question for you, Jarek, is very simple. When you do your first pass analysis, what was the impact of HMA therapy on the model? So you talk about the therapy, but have you been able to really tell us, for the most common therapeutics, how does the model behave?
Yeah, given the number of patients and the fraction of patients treated with hypomethylating agents at various stages, this becomes very complicated because obviously patients who have low risk, they are not treated, but eventually if they progress, they would be treated. And how to account for this? I mean, if we would do a subgroup analysis only for patients who have high risk and were immediately treated with hypomethylating agent. So I think it's an excellent question, but it would require, and I know that there are people who are doing this analysis, because of course, this is not only the therapy, but timing of the therapy would be important. I think majority of us would not treat a very low risk MDS with mild cytopenia with hypomethylating agent. But, so there is also a bias towards when the therapy is deployed. And of course, whether the patients are responders and non-responders. So I don't have an easy answer for you, but definitely this in the novo patient, we would like to have a real world scenario and nobody would assume, okay, if we don't treat you ever in the next 8 years, you are going to have this survival based on your mutation. I think a patient rather want to know what would happen if everything is done correctly.
Thank you.
Yes.
So quick question, please.
Okay, I try to be as quick as possible. This is Jason Chang from University of Chicago. I have two questions or two comments on two of your topics. And the first one is CBL mutation in MDS. Second, I will have some comments on your drug screen asset. So I did not quite get what you said about CPL mutation, different CPL mutation. What's different type of CPL mutation in terms of prognosis and disease classification?
Well, again, not an easy analysis because frameshift mutation in Sybil are by far less common than ring finger mutation. But if you take, so they are significant sampling size issues, applying it to applying molecular prognostication to the impact of Sybil mutation in MDS, particularly if you parse them into this two subgroup. But if you take Sybil, it is an independent poor prognostic factor, irrespective of ELN subclassification in MDS.
Actually, I wanted to bring up actually the important study, two important study, large German study about 10 years ago. Actually, CBL mutations, we all know CBL, including negative regulator of signal transduction pathways. So those German group studies clearly demonstrate the CBL mutation is clustered in the myeloproliferative neoplasm, all MPN/MDS categories. It's so
Yeah, definitely, I agree.
yeah,
with you.
so I would really suggest if you really wanted to diagnose MDS, you find a CBL mutation, be careful. Because if we already know the threshold for CML, I mean monocytes from 1,000 to 500. So those cases, in my experience, the CBL mutations case always almost classed in the MDS/MPN category.
And again, we want to use molecular prognostication and diagnosis to avoid this type of arbitrary cutoff values that are not based. They are a feature of the past. And I don't think that in the future, having, third generation molecular blockers and stimulators, we will worry whether a patient has at that given point 1,500 monocytes or 1,400 monocytes to make a diagnosis which was decided in the boardroom in people who were botics. So yeah, I think, there is definitely a skewing towards myelomonocytic features, but, in our hands, what I wanted to show only with this example, and I didn't want to be controversial, is that the type of
I'm
mutation,
sorry,
even within
Eric,
one gene, might have differential prognosis.
Eric, can you hear me? So
Yeah.
due to lack of time,
Yes.
we have to go to the next speaker.
Okay.
Thank you for the
Thank you.
cooperation.
Thank you very much.
Thank you.
So our next speaker is Professor Naval Daver. He's the director of the Leukemia Research Alliance at MD Anderson Cancer Center, and he's going to talk to us about treatment for MDS with mutant TP53. Thank you very much.
Thank you very much. So I'm going to make this quick since we're late. There's no good treatments for TP53 MDS. Let's go to break. I'm sorry, just kidding. So I'm going to go over some of the background here in TP53 MDS AML, and the truth is there really are not very good treatments, but I'm going to try to move quickly so that we're having at least a few minutes of break. So the big issue with TP53 mutation is really the pervasive impact they have across both the molecular, the apoptotic machinery, the immune system, as well as differentiation. So this is not like FLT3 or IDH or MLL or NPM1, right, that we're successfully treating in myeloid diseases, where you usually have one or two major downstream impacts. Here, pretty much all of the different systems that are important for anti-tumor activity are significantly impacted, which is why it's been really challenging to develop therapeutics there. Now, there's a lot of discussion, and Dr. Zaidan and others later are going to be talking about, what are the optimal cutoffs and differences between ICC, WHO. We've already had some of this discussion this morning with Dr. Bernard and Dr. Maciejewski. I think what's very clear is that having a TP53 mutation in general, especially those who have associated complex or adverse cytogenetic features, is a very, very poor outcome. And these make up about 10 to 15% of MDS in general. They're enriched in those who have therapy-related or secondary MDS, which could be close to about 30% TP53. There is this growing discussion about, is there a difference between MDS and AML in the blast percentage when it gets to the real TP53, which are the patients who have a high VAF complex cytogenetics, and I'm going to talk about that a little bit more. So just a couple of slides on the WHO and ICC, especially as they pertain to TP53. As I mentioned, Dr. Zaidan will go over the more general differences and similarities. Actually, there are many similarities between them. But when it comes to TP53, the ICC basically defined patients who have any mutation greater than 10% as being considered a TP53 mutated myeloid neoplasm. They do not go into terminology AML-MDS. They just call it a high-risk myeloid neoplasm, which I think is really the best way to approach this, because the treatments, if they work, will probably work across the board. For the multi-hit, they actually use a definition here which looks at patients who have either known more than 50% VAF, which is obvious, then that is going to be involving both alleles, or a known chromosome 17p or loss of heterozygosity. On the WHO, there are slight differences here where they basically say if you have any biallelic TP53, which they define as any 2 or more TP53 mutations, they do not use a VAF cutoff of 10% or 50%, or any mutation with, again, a known 17p loss, then that is equivalent. So they really don't consider the patients with less than 50% TP53 single allelic as a TP53-driven disease, which I think is tricky, and I'll show you some of the emerging data that suggests that. So both of these have slight differences in especially the way that they are defining the biallelic component in the MDS. So there was actually a very nice abstract at ASH just a couple of months ago that was looking at multiple centers putting together their data and trying to compare between the differences between the ICC and WHO and what kind of reconciliation can be had. So one of the things that was noted is that with the multi-hit TP53 using a 10% VAF cutoff, you actually may be missing about 18 to 20% of patients who may have a functional poor outcome if you use the WHO criteria. So the ICC may be missing some of those patients. On the other hand, if you use the WHO definition, there are patients between 10 to 20% who may have less than 50% VAF and may not have associated chromosome 17 that could have a poor outcome, especially in that 10% to 20% blast, and they could be missed. So really, suffice it to say, I think we still need to better define most of these, but when you really look at patients who have more than one mutation, and usually they do have a complex karyotype, about 85% of them do, or they have a chromosome 17 or loss of heterozygosity, this is really the true TP53. It makes up about 85% of patients, and these are the ones where really we need to focus our treatment outcomes. Now, to the question, and I'm not going to go into great detail about it, I don't think it's really that relevant a question. I think what matters is what is the therapy that we can develop. But there have been efforts to show that potentially if you have a high VAF TP53, above 20 or above 40%, then the blast percent may not have as much of an impact. These patients seem to have very poor outcome. These are the TP53-driven disease. One of the seminal papers that kind of led to this discussion was by Grob et al. However, there was recent analysis, again from ASH 2023, showing that in a larger analysis, when they looked at a big number of patients, they did not find the same to be true. And in fact, if you had a biallelic TP53 and you had a higher blast, as Dr. Bernard was mentioning, the blasts do have an independent morphological significance, and those who had above 20% blasts did have a poor outcome compared to those who were 10 to 19 or those who were 5 to 10% blast. But again, in the end of the day, all of these have quite a poor outcome. We're kind of hedging between 6 and 8 months and 12 months, so all of them are poor. But yes, there may still be a value to having a blast demarcation for purposes of classification and treatment. Now, what really probably starts mattering is the type of MDS. Is this a de novo or therapy-related? Therapy-related are the ones that tend to have a high enrichment of high-risk TP53 mutations. These usually are biallelic. They usually have a high VAF, and they usually have a poor outcome. There are some patients with de novo MDS who may have a single VAF low TP53 type mutation, and this may be important because these are the patients you want to consider for whether it's intensive chemo, HMA-VEN, and transplant curative options. So especially in de novo populations, it is probably important to not discard all TP53 mutations as being made equal, homogeneous, and treat them with a nihilistic approach. You may have some patients who actually could have a long-term survival and should be given the total therapy approach in that population. Now, Dr. Bernard and a group, I think, have published one of the best risk stratification outcomes in TP53 mutated MDS, where they really were able to show that those patients who had biallelic, which they defined as multiple TP53 mutations, or those with a known deletion 17p or loss of chromosome 17, had a very, very, very poor outcome. On the other hand, those who had a single hit TP53 with a lower VAF may have a better chance of outcome. Again, these are the patients you may want to consider for a full curative treatment sort of approach. So let's look at a patient example. You have a 67-year-old, this is very common, of course, age for MDS presentation, coming with severe cytopenia, has 15% myeloblast. Doesn't really matter to me, the nomenclature at this point. What I'm really waiting for is the molecular and cytogenetics. If this patient tends to have a FLT3 mutation or IDH1, IDH2, or MLL, I'm going to be treating this patient with a targeted therapy-based approach. If they don't, then we're probably going to be going for either low intensity or potentially intensive if they have an NPM1 type of mutation. So really, when we see these patients in clinic today, to me, what is really most important is not the 16%, the 22%, the 28%. It is what is the molecular cytogenetic architecture of this patient. Are they sensitive to intensive chemo, targeted therapy, or HMA, and we make a decision. Now, this patient you see has a TP53 with a pretty sizable VAF. Let's assume the complex cytogenetics is present, which is seen in about 85% of these patients. So this patient would be really high risk. So what are the options you have for such a patient? You know, for TP53, I think we say this for all groups, but for TP53, this is true beyond any other group. You really want to put these patients on clinical trial. If you have them available, this is probably the best chance to give this patient, as well as for us to move the field. The other thing is transplant, in my view, and we can discuss this, should be really strongly considered for these patients. There are certain factors that can improve your transplant outcomes, such as, of course, achieving remission, decreasing TP53VF. But even without that, I really think we should be considering these patients a transplant if they have a good donor and you can get some degree of disease control. Because even though it's not great, the survival with transplant does have a tail to the curve, 25-30%, and is better than no transplant, as has been shown. Now, looking at the various therapies, and there are a number of references you can see. A couple of these were done by us at MD Anderson. So the one here where I look at the VAF cutoffs, this was actually predominantly AML. But what we were able to show is that there is a group of patients in AML, it was about 15% of all TP53, who had a low VAF, less than 40%, had a single mutation, and did not have complex cytogenetics. So this is not the common type, but it's about 15% of your TP53 mutated. And these patients actually did well with intensive chemo and transplant. So today when we see TP53, these are the first questions we ask our hematopathologist. What is the VAF? What are the associated cytogenetics? Is there a chromosome 17p involvement? If not, we're actually treating these patients with intensive chemo, whether it's FLAG-IDA, sort of frontline approaches, taking them to transplant, and they may have a 2-year survival of close to 40%. So you don't want to miss that potentially curable group in the entire consideration of TP53. The other big question that's been burning has been, what about the DAC10? There was this data from WashU showing that there may be some signal of improved response survival. We actually took that signal, we put it in a randomized study. This was 50-50 patients, and we actually did not find any significant difference with DAC5 versus DAC10 in TP53 mutated patients. This was more in AML, but I personally don't think that there is too much effort that needs to be put in the DAC10 regimens today for TP53 mutated patients. This was actually a very nice analysis that Dr. Kawan, working with Dr. Zaidan, has put together. This was looking at 800 patients with high-risk MDS who were treated with frontline single-agent HMA-based therapy. And they basically looked at the response and outcome. What they were able to show is that clearly having a TP53 mutation was associated with both a lower response rate, about 18 to 20% response rate when you look at CR, as well as a inferior survival in this entire population. Now, when you look at it, they found that if you use the WHO criteria, there was almost 40% of patients who are categorized as monoallelic, because it's a little bit more permissive in how it defines the monoallelic population. However, when you use the ICC, or actually the one Dr. Maciejewski talked about, using a functional cutoff of 23%, you then actually are able to start identifying populations which are small, maybe 10 to 20%, but could actually have a favorable survival. But all in all, with HMAs in general, you are seeing kind of a similar approach and similar outcome as compared to intensive chemo, which actually does better in those with low TP53 and a monoallelic hit. Now, there's an interesting data set that's emerging. This is from Dr. Garcia-Manero and Michael Savona using oral decitabine. And, you know, whenever you look at it, it's true, we've never able conclusively shown decitabine and azacitidine difference, but there's always been this sort of signal, whether it's 10-day decitabine, 5-day decitabine, that does have something a little bit different in TP53. So they then use the oral decitabine ASTX727, which is now approved in US and I think in Europe and other regions coming soon, and they were able to pick up 44 patients out of the 130 who had a TP53 mutation, and then they were able to identify which of these were biallelic, So those who had more than 50% TP53 or a chromosome 17, and then the others were monoallelic. So about 30 were defined monoallelic, 14 were biallelic. And what they found was, and this is, again, single-arm study, we have to be cautious, we've seen this before, weren't able to replicate, but it does look quite promising here, where you see that the survival across the board in all TP53 mutated, which was 44 patients, was 25 months. We've actually not seen that in TP53 mutated with any other therapy, so that does look quite promising. And then when they split it, even by monoallelic, biallelic, even in the biallelic, the survival is about 13 months, monoallelic about 29 months. So again, this is kind of thought-provoking, hypothesis-generating. Could there be something different with the oral decitabine that is giving you a better survival? Could it be that it's more in modern times? Are we transplanting more patients? We don't know those, but I do think we have started using more and more oral decitabine in these patients when we have the opportunity, which now in the frontline setting we have routinely because it's approved in that setting. Now, what about transplant? I think that's a big question. And, you know, one can go on for hours about this debate, and I get a lot of patients from other centers where they just say, you have TP53, no transplant. There's no discussion on VAF, chromosome, et cetera. And I think that is really a disservice to the patients. We should really be careful about such a sweeping decision-making. In fact, there are now at least 4 analyses that have all shown that there is survival benefit with transplant compared to no transplant. But yes, in the end of the day, with the biallelic TP53, survival is poor. So this one is one that was presented by the British group, Justin Loki, Charlie Craddock, and colleagues, where they looked at overall survival in TP53 mutated versus wild type. Clearly, you can see there that the outcome in the mutated group is worse. But then when you take, again, that group that is not the high allelic burden and don't have associated chromosome 17 complex karyotype, which actually was almost 30-40% in their analysis, look at the survival in that population. The 2-year survival was 60%. In fact, statistically, it was the same as those who did not have a TP53. So again, there could be this 20 to 30% population that we don't want to club in with the rest of the TP53 and could have a good outcome. Similar data from the Moffitt group, where they looked at allotransplant. Here, actually, they do show clearly that both the single and multi had inferior, but again, they'd have about a 23% survival at 3 years. If you had no transplant, the survival at 3 years was 10 to 11%. So, you know, of course, it's depressing, but at the same time, 23% is better than 10 to 11%. And at MD Anderson, we routinely are offering transplant in remission to these patients. We, of course, would like to see molecular clearance, but we know that that is only seen in about 20%, so we don't hold back the transplant if we don't have molecular clearance. Now, molecular clearance is something that's not routinely being done, but when it is available, I think it may give some good insights as to who could benefit the most from transplant. I still would probably proceed with transplant if it's available, donor is ready, and the patient is in good condition, but maybe in future trials we can start using molecular clearance as a good surrogate to start understanding the early responses. Now, the main question that was asked really is, what about venetoclax-based treatments? And I have to tell you that more and more as we are looking at this, we actually have a large analysis ongoing at MD Anderson with one of our fellows, Dr. Senapati and Dr. Garcia-Minero in our group, looking at a big group of patients with MDS and AML, and we haven't published it yet, so I'm not sharing the data, but I will tell you, and all the previous data also suggests that venetoclax has very, very little to no benefit in the real TP53s. Those are the high VFs or the ones with complex karyotype or chromosome 17 abnormalities. This is not surprising when you look at the bulk of the data from AML. This was a single-arm phase 1b studies and the decitabine 10-day venetoclax studies. You see that even though there's a response signal, and everybody always focuses on the response signal, it's there, no doubt, 55 versus 35% response, but the survival has always been 5 to 6 months in TP53 mutated in the single-arm study, in the decitabine 10-day venetoclax study, and especially when you look at those who have higher VFs, above 40%, you actually start seeing that there's almost no response in that population. This was an analysis from the IPSS-M single-arm phase 1b study, where you see that in those patients who have greater than 40% VF TP53, very low responses and very poor survival. And this is because you do actually need functional TP53 to activate the BAX pathways as well as the NOXA pathways, which are very, very critical to induce pro-apoptosis. So even if you block BCL2 anti-apoptosis and you don't have active BAX signaling or NOXA signaling, which is dependent on a functional TP53, you're actually not going to get significant apoptosis. And that is what we see in a lot of these patients. Now, looking at the overall IPSS-M study, I'm sure you're all very familiar. This was, of course, done, led to approval. We have been looking at subsets of this in AML, and one of the subsets that we're focused on to really answer this question, hopefully more conclusively, is TP53. Again, when you look at it, the CR/CRh rates are better in TP53, poor risk or intermediate cytogenetic patients. But when you look at the survival, this was actually a nice analysis, which will probably lead to a new ELN for the Viale-Aza-Ven backbone therapy. You see the TP53 mutated continue to have a survival of 6 months. So what I would say in a practice setting is if you have a patient who's above 70, 75 and is not going to transplant, and that additional CR/CRi is not going to really help you too much unless you're bridging to transplant, we actually are considering HMA alone. One could do oral decitabine ASTX, or of course other clinical trials adding novel therapies. In the MDS setting, there is earlier data. There's phase 1 single-arm data. This is from Dr. Jacqueline Garcia and Dr. Garcia-Manero and colleagues who have been doing a multi-center single-arm study showing that there is a good response rate, about 33-34% in general with HMA-Ven. This is not TP53 focused, but when you look at the TP53 subset, yes, the overall response rate is good, but the true CR rate is only 20%, actually lower than that, 16%. So again, here, this may be going similar to what we're seeing with AML with HMA-Ven. I think in the afternoon, Dr. Garcia-Manero may be talking about it. One of the questions sometimes we get asked by the community and other treating physicians is, what about CPX? Simple answer, actually CPX also in TP53 is not showing much of a benefit. You could try it, you could move to transplant, but there's nothing to support it. A couple of the new drugs that we were all very excited about, and probably is the reason we're discussing TP53 separately, but unfortunately have not panned out. APR, which was a protein remodulating drug that was supposed to have kind of a direct targeted sort of approach for TP53. Early data by David Salmon and group single arm, as well as the French, showed a very good signal, CR rates for 45-50%. There was molecular clearance in about 20% of the patients. Survival was looking at around 12 to 14 months. And so we thought and hoped that this would lead to a phase 3 positive outcome. Unfortunately, the phase 3 study did not meet its primary endpoint. The CR rate was better. It was actually 50% better, 22 to 33%, but that was not sufficient based on the size of that study to generate a full approval. And unfortunately, given the small size of this company, APR has not moved forward. I don't know the status of it at this point. Then, of course, immunotherapy is what we often turn to for our most difficult populations like TP53. There are many different ways you can do immunotherapy. I'm not going to go into that in detail, but the one that has been of interest in MDS AML has been the CD47 SERP alpha blocking, the idea of blocking what we call the do not eat me signal, activating macrophages to fight against tumor cell. I mean, biologically was shown by Ravi Majeri, Irv Weisman, and many well-known scientists to be quite important, and we thought in the clinical setting this would be something worth trying, especially because there is a synergy potentially with HMA. So this led to studies with the first CD47, which is magrolimab. There are others in ongoing development. This was a large phase 1b study, had about 95 MDS and about 80 AML patients. We did start seeing very early on, and this may be something that has played a major role in the phase 3, and we'll be hopefully presenting that data at one of the large meetings this summer, but anemia was something that was noted. Now, in big academic centers that have blood banks on site and can give transfusions like we did and Moffitt did and others, this was manageable. We actually have had treated about 150, 160 patients with azamagro and have not had a single death from anemia, but that may not be the same when you go to smaller academic or even community centers or other centers in other regions. And I think the anemia did probably have a bigger impact once we globalized this study than what was seen in the initial 10 to 12 centers, which had very good ability to get blood the same day. Overall response rates here, and I think this is why we have to be cautious, we're about 33-34%, which is very similar to what you see with Aza-Ven, and that's why I think we're all hoping that Verona is positive, but are a little bit nervous because these have not always translated into survival benefit with magro, with pevonedostat, with sabatolimab and other drugs. Survival here actually for the TP53 looked quite good at about 17 months, and 80% of these were biallelic. And I think another interesting thing is our transplant outcomes are getting quite good. And you'll see this from the enhanced data when it's presented. Both the Aza placebo and Aza magro arms focus on the transplant outcomes, and I think it's quite surprising and better than what at least me and many of us were thinking it would be. So in the randomized study as well, we're seeing those who go to transplant can have quite a long-term survival. Now, is the field of CD47 SERP alpha dead? I do not know. We saw this with FLT3. The first FLT3 inhibitor was negative. We saw this with BCL2 inhibitors, oblimersen, obatoclax. They were negative. We've seen it with JAK inhibitors. So I don't think it's necessarily that the pathway doesn't work. I think it could be finding the right drug with the right safety efficacy combination. And the good news is that there are many companies still looking at this and even moving to more advanced bispecific engagers that may activate both the innate macrophage as well as the adaptive T cell system. And many of these actually do not bind RBCs because they were structurally designed to not have the similar profile as magrolimab, which may be helpful. One of these that we're working on is a bispecific, which kind of has a cool technology where it can activate both the T cells and the macrophages by two different receptor arms. One of them is towards CD40 on the T cells, the other is towards SIRP alpha, and does not have any RBC binding. This is very early. We showed the data at ASH. We'll be updating it at EHA coming up, and we are seeing good safety and some early signals of efficacy, and of course the study is focusing on high risk. Now, in the last couple of slides, just so that you're all not depressed before going to break and lose your appetite, I'll show you some of the interesting approaches. You know, the research in TP53 today compared to 5 or 10 years ago is tremendous. I mean, I think we're doing much, much more. There's a lot more funding. There's a lot of drugs going into that space. It's a tough disease, but it's similar to what we saw with FLT3 10 years ago, which then led to, as you know, 4 FLT3 inhibitors, and I hope and think the same will happen in TP53. I personally think immunotherapy, and especially CAR-T or NK approaches, may be the way to go. There are some early signals that are moving into larger studies. One of them is a CD7 CAR, actually from China, that Dr. Peggy Liu and colleagues have been doing, and I think this could be an approach that can work across the board. It's an off-the-shelf CAR-T. It could work in AML MDS. It should be mutational agnostic, so we're moving this into a multi-center study. The CARs will actually be generated at the GMP facility at MD Anderson, and this will be looked at in T-cell ALL as well as in AML MDS high-risk populations. And then a very interesting approach, and I cannot share much data, but hopefully you'll see some of this at ASH, that we're looking at is using a CAR with the protein module towards a target antigen. And only when the triple complex of the protein module, the antigen, and the CAR are engaged, you activate the CAR. So this has obvious benefits because you can shut down the CRS toxicities by stopping giving the protein module, and you can also give more of the module to enhance the activation of the universal CAR. And this looks quite promising. It's very exciting. And again, hopefully we'll have data later, but it's also going to allow MDS. Initially, the study was AML, but we will be allowing MDS as well. And there are other constructs. So I'm going to stop over there. I think it's a tough field, but we're all here. There's a lot of research ongoing, and I think in the next 4 to 5 years, we will have breakthroughs that will improve the outcome of TP53, like with other molecular groups. So thank you all very much, and happy to take any questions. Yeah.
Thank you. This was a very informative talk. Please go ahead.
Yeah, quick questions. Can you comment why this P56 target drug did not work, did not show? I'm not aware there's any functional assay to assess, because we always do the mutation assays, but it does not really tell the function, which means P56 binding to DNA forms complex. So are you aware of any people doing the functional assays, or how to assess this drug effect in those cases?
So no, I'm not aware of functional assays for TP53. We are aware that about 90% of the TP53 mutations are dysfunctional mutations, but there are a few, you're right, that may not have the direct significance. Why the drug failed, I think it's always semantics, what failed. I think the study was not appropriately powered. I mean, if you go to a solid tumor conference and they tell you have a 50% improvement in your response rate, there's no way that drug will not be approved. But the study was so small that even with a 50% CR improvement, they did not have the statistical power. It was P 0.1, and it was negative. The same study, 300 patients, would have been positive, but that's what happened.
Yeah, to me, actually, I think it's just a big barrier here. Is we don't have really good assays to assess the function of how the drug works to measure this drug effect how to affect the function of P50 binding to DNA. So we really don't know. We really based on the clinical outcome to say it's not work, it's not work. It's okay, but it's indirect. So we don't know exactly what
I agree. It's not a direct targeting. No, I totally agree. The APR actually, if you look at it, has a lot of ferroptosis effect now. That's kind of what people are learning, and may have other indirect effects that were more important than the direct effects, and may not have been something that had to be restricted to TP53. But you're right, we often learn these things after the story is done, which is not ideal. I agree, yeah.
So I'm Masa from Nagasaki University. So thank you very much for your great talk. And I wanted to ask you about how we can identify the TP53 mutations who can get the benefit from transplant. So I think the clone size or the clearance of TP53 mutation is important, but is there any other biomarkers to identify or to predict the patients?
No, and I think this is something where, we talk about this, but this is really where you have to talk to your patient in detail and counsel them, right? I mean, we have this pretty much every week in our patients. You have a 60-year-old, a 55-year-old, they have TP53. Most of them are going to have high VF or associated complex cytogenetics, so they're poor risk. And, from the beginning, I tell them, this is a tough disease. We are going to try to get you in remission, move to transplant, but with all best efforts and with the best sequence, it's still 25-30%. But if we don't do that, it's about 5%. And so that's kind of, it's a rock and a hard place, but still there is a potential curative option. So usually we will consider transplant for all patients, but for sure, those patients who have a single hit TP53 with a low VF without associated complex cytogenetics, which are not the common ones, but they're there, for them we treat them almost as if they don't have TP53. We just treat them with the full sequence and transplant. So I would transplant all. I don't think we're yet ready to use molecular clearance of TP53 as a surrogate to decide who should get transplant or not. I think that's very tricky. Only 10 to 15% achieve it. If you get more sensitive tests, less will achieve it. And the saying is don't let perfect be the enemy of good. So I think good is okay for now. Maybe in the future we'll get better with therapies. But we are transplanting a lot of these patients, and Dr. Popat in our group has data he'll be presenting later this year where we have about a 30 to 33% 3-year survival. So it's not zero, it could be more, but without transplant, it's less than 10%. That's, yeah.
Thank you very much. Very interesting talk. So I would like to come back to timing and to a sort of a molecular remission or molecular response. So we published with Seishi last year a big study on HMA where we see, it's particularly the P53 that goes down. The interesting thing is that it goes down for 1 cycle or 2 cycles. You've seen this. You give them an ordinary HMA, absolutely not venetoclax, because then you just put them into intensive care unit and lose time. And then you see after 2 cycles, a perfect response. The VAF is down, and all the blood values is up. And then you think, well, transplant, and you wait for 1 cycle or 2 cycles. By cycle 5, they are back in, the VAF is back. So this must be some kind of immune reaction. But we also know that those that we manage to get down, those are the ones that you now report that we cure. And we also show that in this article. So I wonder if we should be a bit, and we know that they respond to GVHD, to the GVL effect. It's a numbers game. You can't have too many cancer cells if you have the T cells you have. So perhaps we should rethink, perhaps we should on these patients harvest the bone marrow, put it in the freezer, follow them every single course before and after, and then say, now it's the day, and then they should be transplanted within 3 days. Yeah. Because everything is so rapid. So I think we have to rethink.
I agree with you. So what we're doing, we have a big program in Anderson similarly where we, on day 1, get our transplanter. We have a protocol for this to come and see them. And we say our goal is within 60 to 80 days to move these people to transplant. We don't want to do exactly what you said. I completely agree.
You must have the donor
it should be ready, and you give 2 cycles, maximum 3, and you move. Yeah. And venetoclax, the more we look at the data and the more I'm analyzing it, more I'm getting concerned about the benefit. In fact, I think there may be even detriment in some of these cases. So I think if you have a good patient ready to go, ideally, if you have a trial HMA with an immunotherapy, that may be a good option, fine. You move quickly to transplant. You do post-transplant early withdrawal of myelosuppression. Now there's post-transplant manipulations, NK cells, DLIs, do the total therapy approach and try to...
So we have a drug, and that is immune effect, whatever that means. We just have to learn how to use it.
I agree. Yeah.
Thanks.
Yeah, thank you.
I think it's time for all of us. Thank you to go for a break. Thank you very much.